All right, so we are going to close the workshop with two individual presentations and then an opportunity for public comment and further discussion with the aim of adjourning around 4 o'clock. So our next presenter is Theodore Cicero, Ted Cicero from Washington University. Dr. Cicero is the John P. Feiner Professor in the Department of Psychiatry at Washington University. He was the architect of the first post-marketing drug abuse surveillance program imposed by the FDA as a condition for the approval of tramadol in 1992. He served as the chairman of the advisory board, which was charged with developing a comprehensive surveillance project that would detect abuse of tramadol in a timely fashion. This program evolved over time and has now emerged as one element of a much larger risk management program, RADARS, Researched Abuse, Diversion, and Addiction-Related Surveillance. The purpose of the program is to provide a nationwide network of patients entering drug abuse treatment programs across the country who meet criteria for abuse and dependence on prescription opioids. So, Dr. Cicero, the floor is yours.
I think he read all that off. He didn't memorize that. So I know I'm the second last speaker. It is Friday afternoon, and our crowd is thinning, so I'll try to be brief as I can and just go over some of the highlights. Fortunately, the earlier speakers did me a great service. I wasn't sure coming into this how much you knew about post-marketing surveillance, how much you knew about REMS and all the rest of it. And it's quite clear you know a great deal about it. So the first 10 slides are going to go by very quickly. Obviously, the whole purpose of the post-marketing surveillance studies at the beginning was phase 1, 2, and 3 testing for drugs before approval are based on really small numbers of individuals. And if you have relatively rare events, you're going to miss it. And you could then inaccurately predict that this drug is going to either be safe or it's going to be harmful. You could just miss it because you're talking about patients very often of 2,000 or 3,000 in these sorts of trials. So a relatively rare event is going to be missed entirely. That's factor one. Factor two, predicting abuse potential in humans based on those studies used to be the gold standard of how you assess these drugs, but it's quite clear they don't predict accurately what's actually going to occur once they're marketed. The drug culture is very unique. They develop preferences for drugs based upon a whole series of factors: cost, availability, the dangerousness of it. They don't want to kill themselves. They want to know something that's going to be good for them, to give them a high that they're looking for, but it is going to kill them. So even though you can say this drug like a Tapentadol came out recently, which is a derivation of tramadol, it looked like a class 2 drug as you looked at the Controlled Substance Act. Its abuse has been zero. There's no interest in it whatsoever. It's got a very limited market. It's been no penetration. So again, just an example, if you had predicted all of the results based on phase 1 and phase 2 and phase 3, you'd be misinformed and perhaps make the wrong decision. I think the FDA recognized this back earlier. You needed post-marketing surveillance, and that really meant that companies had to be very aggressive and proactive in actually looking for abuse, because most of the current systems that we've got, TEDS, Dawn, I think I've got them listed up here. These are some of the monitoring systems the FDA still uses, but up to these post-marketing surveillance instruments, they were the only ones available. These are very passive systems, for the most part. People call in or people report something. The reports aren't in fact elicited, and you get very modest amounts of information from that. So this clearly wasn't enough. You had to be proactive. You had to go out and take a look. There are a couple of these post-marketing surveillance programs out. One is RADARS, which the moderator introduced for you. And I do have one component of that, looking at people entering treatment and asking what drugs are new in your area, what effect you're getting from the drugs. Very useful in determining trends in abuse in a much more timely fashion than those other passive systems. The passive systems, which are still relied on to a certain extent, I don't think they should be, just record after the fact that events occurred. they're not usually published for a year and a half, so we're always a year and a half behind the trend. So something could be occurring with heroin and other kinds of drugs. We're not seeing it for at least a year and a half, and the problem has already become a very large one. That has to be corrected, and the whole purpose of post-marketing surveillance studies was to, in fact, serve as an early warning signal that we have a problem, there's something on the horizon, we need to start acting now and not wait till it's killing hundreds of people, as is the case right now with fentanyl. The identification of the risk is fairly easy. It's a lot of work goes into it. But we basically, with our treatment centers, we can collect 20,000. We have over 25,000 people in the treatment base now, and we can ask them questions directly. What are you taking now? What's new on the street? What are the costs? You can ask a whole bunch of questions, get a very early indication that you've got a problem, and you can have clearly identified the risk. There's no doubt about that. We've gotten very good at that. It's what we do with the data once we have it. That's the problem. Mitigation, as you heard with REMS, is really a difficult process. And what I'm going to propose basically is, I don't have the answer to it. It's going to take a lot of collaboration between the drug companies, National Institute on Drug Abuse, which incidentally doesn't really view this in a whole way as their problem, because in a sense they believe drug safety and abuse is one aspect of drug safety. It should be taken care of by the sponsors of the drug. Drug companies make the drugs, they make the profits, they should pay for the studies. That's a misinformed approach from my perspective, because that's just not going to happen. The drug companies are not going to spend the money if they don't have to spend the money, or they're going to ask, what are the minimum requirements that you're going to expect from me, and I'll do the minimum. It costs lots of money to do these phase 4 studies, and they're going to avoid the cost if they possibly can. The FDA then is stuck with this situation where they're saying, well, you've got to develop mitigation strategies, but no one really knows quite what that is and what it's going to end up being. Now, there's both the supply and demand, and I want to focus on really this point extensively. There's the supply side. Obviously, there's dealers, there's physicians that are pill mills. We've got a whole bunch of various sources. That one is easy sort of to interdict in a way. The DEA gets very excited about that because you can build prisons, you can arrest these people for carrying possessed or scheduled drugs. You can actually take some physical action to it, and you get in the newspaper, there's a big drug haul, and we're stopping the supply of the drugs. You may be to some extent, but it's not the complete problem. There really is a need out there. There's a demand for these drugs that is driving this supply. And one way or the other, as long as there's economics involved in it, if a dealer can make money selling something, he's going to find clients that are willing to get it. So you can poke in one area and you can reduce the supply of one thing, and it's going to pop up in something else. These people aren't going away. Most post-marketing surveillance systems fail to examine mitigation because it's so difficult. Again, if the drug company is not charged with trying to understand why a patient takes this drug or why a non-patient on the street is taking the drug, they really got to find out why or what is it attractive about that drug that's driving this demand. Current focus, again, is on supply. And this sort of gives you an indication if you take a look at it. This is dealer, this is doctor's prescription. Could either be through a pill mill, it could be through a regular physician, could be a friend or relative, forged prescriptions and stolen. And internet has been reported occasionally as a significant source. It really isn't. You don't really get any scheduled drugs coming through the internet. Maybe some of it, but very little. These are the male-female differences here. But I think the next slide is really interesting. If you look at just dealer and physician, which is the major two sources that you saw on the previous slide, divided by males and females and age. You can see dealers are used commonly with someone younger, but as you get older, dealers are used less and less frequently. They're developing appropriate cautiousness for their age. Physicians, on the other hand, sees the opposite effect. Now, clearly, some of this is due to the aging population, but it's disproportionate to what that should actually be. I think people that are older have a much more sympathetic case to make when they go to a physician to get a prescription, and they're less likely to believe that they're scamming them. And I think if you've got a healthy 19-year-old coming in asking for a prescription and a 65-year-old person, there's probably going to be more inclination to want to give it to the 65 than it is to the 19-year-old. Okay, supply-side interventions. There's a whole bunch of them been put in place, and I'm sure over your series of meetings you've heard prescription monitoring programs, crackdown on pill mills and script doctors, physician education, which you've heard a great deal about, and the CDC prescribing guidelines. All of these are efforts, again, to limit the supply. One of them is abuse-deterrent formulations, which you heard a little bit about earlier, but I want to kind of focus on that to say, what is the consequence of abuse-deterrent formulations or tamper resistance or whatever you want to call them? What are the consequences of that? And are they effective? Because the FDA is really pushing them now in a direction, and companies are making all these abuse-deterrent formulations. There's the anticipated effects, reduced opiate use. And I will use the example of OxyContin. Again, this is the OxyContin prior to its abuse-deterrent formulation. The nice thing about this is it's a clean experiment. There was no abuse-deterrent formulation throughout this period. Introduced right here, and you can see what happened to abuse. It was effective. It reduced abuse by substantial amounts, but look what's happened here. It's leveled off now, and we're down at a stage that it's still remaining 30 to 40% of the population. These are people entering treatment endorse the use of OxyContin. A lot of them take it orally, and so maybe the abuse deterrence has to be against crushing and against injecting IV, but a lot of them have figured out ways of getting around it. It isn't that difficult. You have some very clever chemists on the internet who basically can ascertain quite quickly how do you solubilize this, how do you inject it or snort it. And I think we probably are eliminating some of the snorters and the injectors, but this is primarily, all right, let me back up for a second. This is primarily a reduction in the ADF, the original ADF. These are probably mainly oral, but surprisingly, a good third of this population is actually still injecting it and snorting it. They figured out a way to beat the ADF. No ADF is perfect. What's the unanticipated consequence of the ADF for OxyContin? Again, where did these people go? We asked them, when the formulation came on board, did you just stop taking drugs or did you shift to something else? Well, they shifted to something else, and unfortunately, 70% of them switched to heroin. A totally unanticipated effect. We had not considered this going into it, that the OxyContin users weren't just going away, but if you're going to inject or snort, there's your candidate right there. And a surprisingly large number of people transitioned into heroin at that point. It really dwarfs all the other drugs that go into it. So what we've inadvertently done is create a whole new problem here. We now have a heroin epidemic that's sweeping the country. You've probably all heard about it. And in large part, it's due to not to just ADS, believe me. There's prescription monitoring programs. In general, the supply of opiates is dropping. But the users, again, just haven't simply stopped taking opiates. They just shifted to something that was more readily available. Dealers recognized that and marketed heroin as a much less expensive, and it was easily adulterated, it turns out, now about fentanyl. And it has now become a very cheap, accessible alternative to these prescription drugs that are so expensive. You can see the increase in the use of heroin and opiates, and prescription opiates over time since 2008. It's been increasing at a very steady rate. But notice, there hasn't been really that much of an increase in heroin when it's considered heroin is my only drug. What's happening is people who use prescription opioids, you can see that dropping here. What's happening is these whole bulk of users in here are using either prescription opioids or heroin. And they're using it interchangeably. Whatever available, they'll use. And that's one of the hallmarks of all this is, again, its availability. If it's there, I'm going to find it someplace. And there was very much a reduced stigma of heroin. When we first started these studies, we heard people saying constantly, at least I don't take heroin. I take prescription drugs. They're legal. There can't be anything wrong with them. I'm happy with that. My grandmom takes them, and she got prescribed by a doctor. They can't be all that bad. And they viewed heroin in a very negative way, as you see on TV, going into bad neighborhoods and all. But this is the type of quote, and this is a lot of qualitative. Let me stop at that point. We do standardized questionnaires, but we also have wide open-ended sections. So we can ask the dealers or the individual to describe in their own words what a drug is doing to them, why they take the drug. So a lot of this is qualitative information, which I think is very useful in this particular case. You can see the comment there of the two dealers and the people around them are middle-aged, middle-class white kids, not even kids. We were all in the age range of 25 to 41. It just became easy, and we weren't really looked at as being addicts because everyone thinks that heroin addicts are all homeless, shady-looking, dirty junkies. I knew I liked it above all else, and once I had a drug dealer, it became almost too easy to get. I had access to money because I'm an upper-middle-class family, and I also became close to my dealers, driving them around so I could get paid in drugs and just becoming super close, even if it meant sexually, so I could get the drug. Understanding the demand, here's, I think, what really is where we have to focus our efforts, and it's the most difficult step to take. but it is necessary, and I think the committee is going to have a real tough time. This should be your charge ultimately, I would say, is the demand side, because that's where the action is. If you don't have demand, the supply will dry up by itself. If you just try to attack the supply side and don't address the demand side, you're going to lose this battle, and we are losing it in ways in which that are quite negative. The heroin, I would argue right now, especially that being laced with fentanyl, is a very serious threat to public health. And in some fashion, we have created this by attacking that supply side too aggressively. Getting high, several quotes again. I love the feeling of euphoria. I finally felt comfortable in my own skin. I could talk to anyone I felt what I thought I was supposed to feel like. Extremely happy. I know he had found the secret to my happiness. When it's not in there, though, he said, instead, I've gone to hell, is the remainder of that quote. And this is an important point. Initial high is very reinforcing, but after a short period of time, that doesn't become enough. In fact, there's other benefits to taking opiates at that point. Is getting high the sole motivation? The answer is no. This is a word cloud that measures the frequency of words being used by addicts that will describe what was your high like, what are you taking now? And you'll see these reactions are quite stunning. It's relaxed, happy, numb. We'll really get to euphoria. It's really not all that large an endorsement. Euphoria is important, but there's other kinds of things that make these people quite satisfied. And we focused a lot of time on this effort. I did not have any tools for coping with uncomfortable situations. These are people being asked, why do you take opiates persistently? If your high is gone, why are you taking it? Which made using drugs my go-to coping skill for anything from handling emotional abuse to taking a shower. They made me feel like I could talk to people and not be scared or embarrassed to walk around and just talk and be part of society. I interviewed a 19-year-old young man, very good-looking guy. He was fairly intelligent, but basically said, I'm such a shy person, I can't approach a hot girl. I can't, if in a bar, I would never approach her because she wouldn't like me. People don't like me, I'm introverted. But if I take heroin or a prescription opioid, I'm outgoing, people love me, and I'm actually a much better person. I pick up girls all the time in bars. This drug has restored me to what a normal person should be. And I said, but you're that person. Because you act shy or depressed or whatever, the drug is temporarily making something different out of you, but you are the one who they're attracted to. But he didn't get it. He said, I know what you're saying, but I'll never stop taking this drug because it makes me a better person. And that's a very scary development when you've got that sort of drive for it. Masking inside emotions, traumas, feeling of fear, self-esteem, self-pity, anger, and avoiding the degrading stress and responsibility of life. Notice how high has sort of dropped out of the picture here. They're getting some other benefit. It's not just getting high. So the typical notion, and when you look at questionnaires to say, have you used this drug in the last 30 days to get high? A lot of our respondents, we asked them the question, they didn't understand what the question was because high to them is a different thing than it might be to another person. For them, it was serving some other benefit. I'll skip through these. We looked, as you might guess, we did careful psychiatric screenings of these patients. 75% of all the personnel, this is a population of 20,000, reported they use opiates to self-medicate psychiatric-related issues. 85% self-reported the use of opiates to escape from life. There was no difference between those who started using from a doctor's prescription and those who used it on an experimental basis. But there is an underlying psychiatric disorder that we need to be addressing in a very systematic sort of way. My conclusions are pretty simple. The old adage, unfortunately, with treatment is about 25% of the people get better, about 50% remain unchanged, and about 25% get worse. That's a pretty sad statement of our treatment programs, but that is sort of the reality. And I haven't seen much data suggest that the figures are very different. You see people like AA and others playing games with numbers, but the real reality is it's a very difficult disease to address. Abstinence-based programs are certainly the goal. You would love to see that occur. But right now, we're not treating the underlying problems as well in our treatment or our prevention approaches. We've got to be attacking the fact that these people do have some psychiatric disorders that need to be treated along with whatever drug mechanisms you're using to get them off the drugs. They have to be there. I would suggest that methadone and buprenorphine are not the answer. I know I run into a lot of resistance to that. They're certainly good for harm reduction, I don't deny that, but they're not really solving the basic problem. If you've got people with very low self-esteem and you've got people who think they're better on taking these drugs, you're just giving them another drug to take the place of drugs that could be used. So we need abstinence, but clearly we need treatment programs and prevention programs that look to the individual and say this individual isn't just a drug addict. A drug, actually, I would argue the drug intake is actually a symptom of a much more serious issue, that in fact should be the focus as we go along with treatment and prevention programs. Now, the difficulty with that is that this is almost an impossible task for the FDA to do. How do you mandate that this be done? I understand that. I think we need to, that's why I suggest your committee could have another charge at some point of looking at this. How do we best communicate that? How do we start? And it works. I mean, it's worked very well with smoking and other kinds of things where you can educate people that you're taking drugs for a reason. And it's not just to get high. It satisfies some need you have. Get involved in that and try to identify what that need is, because the ultimate goal of all of these efforts, post-marketing surveillance and REMS, is eradication of the substance abuse problem that's ravaging the country. I would suggest we're not doing that at this point because we're not attacking the base cause. So we see a drop in people using prescription opioids, but we see a rise in those using heroin, and who knows what's next. I can't predict what's going to be next, but it'll be something. Now you've got fentanyl and acetylfentanyl. You've got these more and more potent analogs coming along that, in fact, if there's that need again, it's going to be met. So I appreciate the difficulty that this committee has certainly trying to digest all this. And the FDA, who I agree with Nat. I mean, this is a really serious, difficult problem. The FDA is in a very awkward spot trying to deal with it. They can do what they can do. The DEA is of no help in that respect other than because their interdiction model is all they can think about. So we're focusing on supply, which is easy to do. And believe me, it has a role. We want to reduce supply as much as we can. But the fundamental base problem remains the same. As long as you have that demand for the drug, it'll always be met. We know this from Prohibition. And we banned alcohol. It was made illegal. It had not a very nice outcome for a whole bunch of reasons. The demand certainly didn't go away and gave rise to the mafia and all kinds of other things. Total abolition doesn't work. You're still going to have drugs filtering in, and we have got to treat fundamentally the individual who wants to take those drugs for some benefit. I'll go ahead and stop there. Thank you.